There's tissues right there. He was getting her tissues.
Oh, what a sweetheart.
I gave her tissues, so there's tissues there. But now she has extra tissues.
All right, so ECMO is used on neonates. It is used on pediatrics. It is used on adults. So even though I'm teaching this during the neonatal lecture, it really applies to a lot more than just neonates. ECLS is I guess the proper name, extracorporeal life support, and it means to remove blood from the body, oxygenate it, get rid of the carbon dioxide, and then put the blood back into the body. So that's ECLS. However, you never hear ECLS mentioned, you hear ECMO mentioned. So that's extracorporeal membrane oxygenation. So that's pretty much the word that you're going to go by is ECMO. All right, so who is put on ECMO? It says that when it is nearly impossible to maintain adequate oxygenation with current methods of mechanical ventilation, what else is available? And that's when ECMO would be indicated. There's another reason to place a patient on ECMO, and that is to support circulation. So if patient has heart failure and they don't have a good enough ejection fraction to support their life, then something has to be done. Otherwise, they're going to die. So if there's hope that the heart is going to recover, then it's okay to put them on ECMO, let the ECMO machine help their heart for a little bit until their heart recovers. So with infants, it helps to use ECMO for those that have respiratory failure, that have not responded to inhaled nitric oxide, or they're placed on high frequency ventilation. That's not helping. So then ECMO would be the next modality to try. Babies that are born with a congenital diaphragmatic hernia, of course, having the intestines up in the lungs don't develop normally. So to put them on ECMO with the thought that let their lungs have a little bit of time to develop, and then they can support themselves. So they could go on ECMO for short periods of time. Using it in pediatrics, you see it used post-cardiac surgery. So they'll have some sort of heart anomaly. They are taken to surgery. And then after surgery, sometimes the heart doesn't respond. Of course, it was just being manipulated by a surgeon. So the cardiac output sometimes isn't good right after surgery. But then within a few days, the heart recovers and then starts functioning. So in the meantime, they go on ECMO. And then, of course, pediatrics can also have respiratory failure that's not responding to other methods. And then adults, same thing. Respiratory failure, can't oxygenate them, or they have cardiac failure. Here's the definition for ECMO: is to circulate blood outside the body to provide gas exchange. So it's not just providing oxygen, it's also getting rid of carbon dioxide. Up to 80% of the patient's blood is routed outside of the body, and then 20% continues to circulate normally. All right, so how is the blood accessed? The first way, it's called veno-venous. So veno means vein, venous means vein. It's taking blood out of the vein and putting blood back into the vein. So typically that's done by cannulating the right atrium. So they'll put a catheter into the right jugular vein, feed it down into the right atrium. But the catheter has two ports. One port is taking the blood out, and the other port is pushing the blood in. To do this, this helps with oxygenating giving oxygen, removing carbon dioxide. But doing this does nothing to help with heart function. So veno-venous cannulation is only to help with oxygenation and CO2 removal. Do I need to write that, or you guys got it? Yeah. So I wrote, taking blood from the right internal jugular vein, putting it back into the right atrium is called veno-venous cannulation. This only helps with oxygenation. It doesn't help with a failing heart. So that's like the main takeaway point that you guys need to learn from this lecture. Okay, and then let me explain the last bullet. It says pulsatile blood flow is uninterrupted. What that means is when the heart contracts, you're still going to feel a pulse when the heart contracts. When we discuss the next category of veno-arterial, you don't feel a pulse with that kind of ECMO. So pulsatile blood flow is when the heart contracts, you feel a pulse. So when the heart contracts, you can feel a pulse in the blood vessels, which is normal. So that's why it says pulsatile blood flow is uninterrupted. Tiffany?
So you would only use this veno-venous cannulation for respiratory therapy.
Perfect, yes. Good job. Okay, you wrote that? Can I clear it?
Yes.
Yvonne, when this happens, so this blood isn't going through the heart at this time, though, right? It is?
Yeah.
Okay. So the other one you're gonna tell us is when blood's not going through.
It always circulates to the heart.
So how do they do heart transplants? So I thought they just acting do that too.
They'll cannulate the vessel, and some of the blood will go through the cannula or the catheter, and the rest of the blood circulates normally.
Okay.
Mhm. So here's a picture. Trying to get my bearings here. So right internal jugular vein is cannulated. The catheter has two ports. One port is going to pull the blood. So you see the blue arrows. So it's taking deoxygenated blood, it's sending it to the oxygenator. And then the blood is returned back into the right atrium. So you've got the good oxygenated blood now on the right side of the heart, which is different than normal, but it's okay. There's not a problem with that happening.
So it's still gonna go to the lung, and everything is just not gonna really pick up oxygen.
Correct. Yeah. Yeah. The lungs are damaged for some reason. So it'll go there, but it's not picking up oxygen. So the next way of cannulating, it's called veno-arterial access. So we talked about veno-venous, and now we're talking about veno-arterial. So we're taking the blood from the vein and we're putting it back into an artery. So it says deoxygenated blood is removed from the right internal jugular vein. Oxygenated blood is returned to the aortic arch via the right common carotid artery. It can also be returned back into the body to the femoral artery. So doing this, it supports the heart because the blood is pumped into the aorta without the help of the left ventricle. So right common carotid artery. How does that branch from the aorta? So coming off the aorta, isn't the first one the brachiocephalic? And then what's the second one? Or no, brachiocephalic. The cephalic is the right common carotid artery? No. So is it the second one? How come I tell you guys this all the time? I'm retiring and I still can't get that right.
I think it's the first one to feed the heart.
So coming off the aorta. The first one is brachiocephalic. So that cephalic artery, is that the right common carotid artery?
The brachiocephalic branches into the right subclavian and the right common carotid.
Right common carotid artery? Okay. Okay. So they cannulate that artery, put a cannula there, and that's how they're putting blood into the aorta. So instead of the left ventricle having to pump the blood into the aorta, the ECMO pump will push the blood into the aorta. So now the blood gets to the aorta, but not from the left ventricle. I mean, the left ventricle will still have a little bit of contribution, but it's mostly coming from the pump. So when the pump puts the blood into the aorta, it creates a non-pulsatile flow. And if you feel the patient's pulse, you don't feel the pulse. So it's just like a constant flow. It's not like a bolus of blood and then a relaxation, a bolus of blood and a relaxation. It's just a continuous flow of blood. So you don't feel a pulse on the patient when they're on veno-arterial ECMO.
So veno-arterial supports the heart, whereas veno-venous supports oxygenation.
Yes. Yeah, that's the takeaway point. Very good.
How come we don't venal extending? Only you get those back because that's what we do.
Ah, good point. Yeah, how do you get a blood pressure? How do you?
Why, how do you even know they code?
Good question. How do you even know if they're coding if there's no pulse? What did you say, Brett?
If they were coding, wouldn't this still just keep delivering blood body?
Yes. Yeah, so if the heart stops and the pump is pushing all the blood into the aorta, would the blood still be circulating? Yes.
Would you do CPR?
I love that question. So people that are joining us on Zoom, Tiffany is asking, what would happen if this person codes? How would you know they code? Would you start compressions? Would you just turn up the pump? That's a good question. So we'll have to ask Dr. Cohen when we're with him.
Are they even able to code? Like, because their blood is already pumping for them, like, and it's helping like oxygenation? Are they even like, I guess they still can code, but
Yeah, your heart could still stop,
Mm.
even though the blood is still being pushed around. That is
got
weird.
it.
So there's a catheter in the right internal jugular vein that takes out the deoxygenated blood. This picture shows it coming directly from the atrium, but it would be threaded into the atrium from the internal jugular vein. And then the left common carotid, no, the right common carotid artery would also be cannulated. And that's where the blood would be put into the body. So take it from the right side of the heart and then put it into the aorta.
So that bypasses coronary circulation.
Coronary circulation are branches right off of the aorta. So it would also, coronary circulation would continue because there's blood in the aorta that can feed the coronary vessels.
Okay.
Yeah, but with having it non-pulsatile, I guess it doesn't matter. The vessels get most of their blood flow during diastole. So that would continue.
Would the coronary circulation be provided by that 20% that's not being routed through?
No, it could be provided by the 20% that does come from the left ventricle, and then the 80% that's pushed in there.
Yeah, that's what that's what I meant.
Yeah. Yeah, so there's still blood in the left ventricle. It's not like it's empty.
Right. I just wonder where that blood was coming from, I guess. And it all gets mixed up once it gets into circulation anyway, right?
Yes. Yeah, so it does get mixed up. This shows the ECMO circuit. So I'm going through like the basic understanding of ECMO, what you need to know in order to give an adequate report to the next shift, to kind of understand what's going on at the bedside. But as far as running this ECMO circuit, it's a few months of training. I think it's 6 weeks of intensive full-time training. And then after that, you have to work with the circuit until you perfected, putting a patient on ECMO. If the patient crashes or if there's like a blood clot somehow in the circuit, How do you stop ECMO and get the blood back into the patient? So all of that training takes place over probably several months before you're ready to, punch in, and for your shift, you're sitting at the ECMO pump, just monitoring the ECMO pump. That comes with a lot of extra training. And if you are working at Memorial, they're going to kind of pursue you to do this because they need more people to sit the pumps. They call sit the pumps because this circuit has to be attended by a live person continuously. And to have perfusionists who go to school, and that's all they do, they do this during surgery. So if a patient has open heart surgery and they're working on the valves, of course, or the vessels also, the heart has to be stopped. So while the heart is stopped during surgery, how is the patient's blood flowing? And it's through a circuit, but a perfusionist goes to school just to run that circuit. They're very expensive. They get paid a lot higher than a respiratory therapist. And there's not as many of them around. So now they're looking for who else can we get to sit these ECMO pumps. So they're asking critical care nurses, they're asking respiratory therapists, are you interested in this training? It's because we need more help with running ECMO pumps. So let's start with the venous blood being taken out of the body. First thing that happens is heparin is put into the blood because you can't have the blood going through the circuit and then have it start to clot. So these patients have to be completely heparinized, which poses a problem for bleeding. So if somebody is on ECMO and you received an order to draw a blood gas and you stick the patient for the blood gas, they're not going to stop bleeding. So you don't stick a patient for a blood gas when they're on ECMO. If fluids need to be given, they're put into the circuit. So it's kind of like making use of the circuit to give medication, to give fluids.
These patients, would they have like an A line or something that you could pull from rather than sticking? I mean, isn't there somewhere else you can draw that blood for a blood gas from?
Yeah, it's usually drawn where it says arterial cannula on this picture.
There's a port there,
So
right?
right before it goes back into the body, you can measure what the oxygen, the CO2, the pH is. So the pump is what drives the blood through the circuit. And then you have the membrane oxygenator. So that's where you have oxygen coming into the oxygenator. CO2, I don't know how it regulates CO2. But it does. And then now that it's oxygenated, it goes back and it's warmed up and then placed back into the body.
Do you sit there and monitor that machine for 12 hours?
Yeah, I know.
I would fall asleep.
Yes, can you imagine trying to stay alert and awake while this is going on?
Yeah.
It's
And
hard.
also, how do you take break? You make the nurse wash it for you and you go eat? Or...
Yeah. Yeah, to get your 30-minute lunch and your 2 15-minute breaks, and that's it.
Yeah.
Do we get paid extra?
Yes, you do.
Oh.
Now everybody's interested.
Interesting.
Yes, you do get paid extra for this.
Yeah, how much extra? Like the perfusionist?
No, the
No.
perfusionists make like $100,000 a year. I almost did that. The Ferry has a program I looked into.
Oh,
But
really?
so what if you don't go through that program and you just do the training at the hospital? How much more do they?
Yeah, do you get paid $100,000? I don't know if you did it constantly every day, maybe. But
I'm gonna say maybe $3 to $5 extra you probably get.
per hour?
Yeah. That's just a guesstimate.
because it was not gonna be the same as a perfusionist. Perfusionist, a master's, and you can't even work during that program. It's impossible.
Oh,
Yeah.
so you looked into it
But
also.
a lot of respiratory therapists go and do that, and perfusionists, so. Took a
Yeah,
master
so
just
learning
to-
hemodynamics, it gives you that good background you need, so the
Right.
program would be easier to get through.
Just to monitor a machine, take a master degree.
I know.
You know, like,
Never-
I thought it was something
You
about a
never saw
year.
someone at ECMO?
I'm an absent patient on ECMO, but not perfusion.
No, but like usually when you see the patient echo, you see there's always like 2 or 3 people hanging around there, like right there. Yeah. No, no.
I haven't seen.
Did you
people
see that
hanging-
Broward or Memorial?
Broward.
Okay, maybe. Maybe it's different.
Yeah, I don't see people hanging around.
Because when I saw one lady at Memorial, there was like at least 3 people there. Chilling.
I wonder if somebody was in training, because it doesn't take 3 people to chill.
There was like a doctor and like 2 nurses or something, so I don't know. Maybe one wasn't training.
So you hear the term sweep gas, and what that's referring to is a blood gas, but the blood is drawn from the ECMO circuit prior to it re-entering the patient. The sample is a reflection of how well the membrane oxygenator is oxygenating and removing carbon dioxide from the blood. One thing that's not mentioned on here is flow rate, like how much blood is taken into the circuit versus how much is allowed to flow normally. So I told you 80% of the blood is taken out. And then weaning the patient, less and less blood would be taken out. So they can adjust the flow of blood going through the circuit. I'm just going to leave it like that. So the amount of flow that's adjusted, we can ask Dr. Cohen to explain it when we're there with him. Like, how do they know when to increase the flow? How do they know when to decrease the flow? Can the patient be extubated in off positive pressure ventilation during ECMO? And it says not usually. They need minimal ventilator settings to maintain ventilation and oxygenation. So if they have ARDS type lungs, their lungs are going to be really stiff. And to have no breathing occurring, so if the patient's moving their chest and there's no air going in and out of the lungs, you get really bad atelectasis occurring. And when it's time for them to recover and start using their lungs again, it's not as reversible as if you keep those alveoli open during the time period that they're using ECMO to keep them alive. It's going to be gentle ventilation. Peak airway pressures are kept less than 30 centimeters of water. So not even plateau pressure, but peak pressure is kept less than 30 centimeters of water. And you use some PEEP, so 5 of PEEP.
you see patients like this, well, I did see a patient like this in CVICU where they had him on minimal bed settings, and Brian said it was so he doesn't develop atelectasis, because he was on ECMO, but he was still hooked up to the bed as well. And I was wondering why.
Yeah. So now we know. It would be nice because I guess that patient is trached, but I just wonder if it would be more comfortable for them if they don't have a trach tube in, they don't have an endotracheal tube in. They're living, because it takes like 2 to 3 months for the lungs to heal before they come off ECMO. That's a long time to be trached, laying in the bed, can't eat food, you know, you're sensory deprived. How long can you stay like that? So I know in some facilities, they actually get transport ECMO where they get the patient out of bed and walk them around just so they don't develop complete atrophy of muscles.
That sounds like a tax.
I know.
Yeah, I think it's good for you.
Yeah, and don't let any accidental disconnections occur during walking the patient. Can you imagine? Here you are in the middle of the hallway with a
machine, lines, patient barely mobile.
yeah.
Sounds.
Yes, it does. But it is done, and I guess they survive better because I don't know if there's a sense of normalcy when you're getting out of bed and walking around. A calculation used in critical care medicine to aid in determining the severity of illness and probable mortality is the oxygenation index. We talked about the values that indicate severe respiratory therapy, respiratory failure, I'm sorry. It was greater than 19 to go on high frequency ventilation. Do I have a different number written down for ECMO? Greater than 40. So if oxygenation index is greater than 40, then ECMO is indicated. And now for choosing a neonate to go on ECMO. Again, it's repeating the oxygenation index of greater than 40. If kept on conventional ventilation, mortality would exceed 80%. So these are babies that this is kind of like a life or death decision. If their alveolar to arterial oxygen gradient is greater than 610 for more than 2 hours. So to have a AA gradient of 610, what is that, 100% oxygen? How do you get 600 in the alveoli? 700 minus 40. Yeah, they would have to be on 100% in order for that to happen. What's that?
Wouldn't they be over oxygenated?
So to have an AA gradient of 600, that an example would be you're on pure oxygen, and in the alveolus you have a partial pressure of oxygen of 700. But yet you take arterial blood and you measure it, and the arterial blood is 50 millimeters mercury. So because of the edema, collapsed alveoli, the oxygen can't get through and into the blood. And that's what creates that big AA gradient. If you figure out the PaO2 divide by FiO2, you come up with less than 80. Cardiac anatomy must be consistent with a favorable outcome. So that's the big issue. That and the next bullet says must have a reversible disease process. Can you imagine putting somebody on ECMO and you can't get them off? If you can't get them off, if you try to get them off, they're going to die. So now they're kind of stuck on ECMO, and that's keeping them alive. So you don't want that situation to occur. So that's why candidates for ECMO are chosen so carefully. You want to make sure that it's a reversible disease. So with infants, they have to be older than 35 weeks gestation, because if they're less than 35 weeks, there's a high incidence of intracranial hemorrhage. So you might think, oh, okay, we've got these preemies, why, they're born so premature, why can't we just put them on ECMO and just use ECMO to keep them alive until they're a little bit older? But there's so many drawbacks to doing that, it's not feasible. They hemorrhage, they have to be anticoagulated, which is why they have the hemorrhages. Do you know what it means to be anticoagulated? Yes, yeah,
So you don't clot.
right. Okay, good.
Is this intracranial hemorrhage like it increases the ICP pressure or something?
The blood vessels in the brain
just-
bust.
Yeah.
And the blood leaks into the ventricles and
Is
inside
that
the
from a
brain.
higher pressure or from a coagulation?
So why are the blood vessels busting?
Is it the pressure?
I know they bust, but do I know the mechanism as to why they bust?
Is it just because they're so premature? Like I know with the babies in like neonate right now, all of them under like 30 weeks are just, you don't really want to touch them or stimulate them a lot because they're at such high risk for the intracranial hemorrhages.
Yeah, exactly. So yeah, there is the fragile blood vessel in the brain, and that's why it can rupture. But other than it being fragile, I don't know how else to describe it. And then even with the babies that are more than 35 weeks, make sure they don't have a pre-existing head hemorrhage, because if they do, they won't be a candidate for ECMO. And if they have any significant bleeding, then they can't go on ECMO. And again, it's because heparin is being given and blood's not going to clot. So you don't want them to bleed to death. And then criteria for adults going on ECMO. This came from Dr. Cohen. So Memorial Regional is considered an ECMO center, and they take patients from other hospitals that would be a candidate for ECMO and bring them over to Memorial. So if you're working at Memorial, you're going to see a lot more ECMO patients than you would see in other places. So for the ECMO team, to get a referral, I guess it's called a referral or a consult. Hey, we have this patient at such and such hospital in ARDS. Would you consider this patient for ECMO so that we can move them to your facility? So the ECMO team will evaluate what's wrong with the patient. If there's, it lists it here. So it has to be that they're on the ventilator less than 10 days. Because if somebody's on a ventilator more than 10 days, the ventilator, we all know, it damages the lungs. That constant pressure tears the type 1 cells. So if we're destroying their lungs with the ventilator, they're not going to be a good candidate for ECMO. It has to be single organ failure, like just the lungs are failing, but the kidneys are still working, liver enzymes are normal, brain function is normal, everything has to be normal. just the lungs are not providing oxygenation to the body, then they would be considered a candidate. And then they have failed maximal ventilator strategies.
Does it have to be the lungs or any similar word?
It has to be the lungs. Yeah. So what would be some maximal ventilator strategies that we would say, okay, we tried this and it failed?
High frequency.
Bivent.
Bivent, very good. So with proning a patient, using Bivent, if we're still not improving oxygenation, then what else can we do? And that's when ECMO comes into play. As far as mortality of patients who go on ECMO, I think nationwide it's 50%. That's what I have. And I don't have the study that it was reported in. It says, yeah, like 50% mortality. So if there's a 50-50 chance that the person's going to get better. However, being at an ECMO center where they do it all the time, there's a much better outcome. Thank you. If you select the patients carefully and you're only using certain patients, they're going to have a much better outcome than just throughout the country, anybody who goes on ECMO. Also, there can't be a contraindication to anticoagulation because you don't want to have to give them heparin and now they start bleeding somewhere in their body. Make sense? So that's how they choose which patients go on ECMO and which ones do not. Oh, it has it here. So the hazards of ECMO. We talked about the mortality rate. It leads to bleeding problems. Sometimes a clot can form in the membrane oxygenator. So that filter, it looks like a filter, but it's where the blood comes in contact with the oxygen. Clots can form in there. And when it does, it's going to occlude blood flow. And now the blood can't get past the oxygenator to get back to the patient. So that could be a problem. And then at the bottom, never, 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 never. Did I say never? Stick a patient on ECMO for a blood gas because they'll continue to bleed. It won't stop. It seems like every year there's more and more technology to present to respiratory students, and to squeeze it all into 2 years. It's a lot, and I understand that. But still, I want you to be familiar with everything when you're taking care of the patient at the bedside. And working in CVICU, or if you're doing your clinical rotation in CVICU, you come across patients that their left ventricle is just not working well, and it's not going to get any better. So does this person die, or is there something else that can help their left ventricle? So there's an LVAD, the left ventricular assist device, that takes the blood out of the left ventricle, pumps it and pushes it into the aorta.
Is that like the valve is that, or like the ventricle itself, that area is just like not pumping as well as it should?
The muscle is not pumping effectively. Yeah. Yeah, a low ejection fraction is not compatible with life, if it's low enough. So I think like 20% a person can survive on 20% ejection fraction. They're gonna be short of breath a lot. But according to Dr. Cohen, they can survive on a 20% ejection fraction. But I guess if it's less than that, it's not compatible with life. So what can we do? So they put this device in, the LVAD. And then it's implanted under the skin. So what do you see outside the person's body? I guess this catheter, a control unit, the batteries. And I don't know if it's reversible. Oh, that ended the show. All right, so let's take a break. And then we'll get into Velletri. And then we'll talk about assessing the pediatric. Okay, we're ready to continue. We're going to discuss Velletri. And before we do, I just want to talk about the exam for next week or next Monday. So next Monday, when we meet, we're going to meet at the simulation center and do some rapid response scenarios. And then after that, you'll go home, and then around 1 o'clock-ish, maybe 1:30, I'll have the exam open, and you can take your exam from your home in D2L. Make sure you have lockdown browser installed on your computer in order to take it. On the exam, it's going to be the congenital heart defects PowerPoint that we went through, ECMO PowerPoint, nitric oxide, and Velletri. So that's what you'll have to learn and know for your exam next Monday that you will be taking at home. After you finish your exam, we're going to have some lecture. So I'll create a Zoom call, and then we can do lecture after the exam. So that's next Monday. Does anybody have any questions about next Monday and what to expect?
Yes, I was wondering, is the exam on honor lock or is it open book?
It's not on honor lock. It's you just go into, just like you do in the classroom where you go into D2L, you click on the exam. You have to have lockdown browser installed on your computer. And then I give you guys the password, and then you open the test and take it. So it's not on honor lock. It's just you need lockdown browser. Marlon, question?
For the sim center, you want us in our scrubs?
Yes. Yeah, I think that's the requirement, right? Students have to be in scrubs.
And then.
Okay. And then for rounds, rounds are coming up with meeting with Dr. Cohen. If you're at Memorial Adult, Memorial Pediatric ICU, we'll meet with Dr. Cohen on, it's late, like December 30th or something to that effect.
December?
December 30th or November?
November 30th.
Oh.
Tiffany?
Questions.
Yeah.
It's good.
Are used in separate things you
I did that a ways back.
because I don't know very honest.
Could you send me an email and I'll check as to why?
And then my second question is, so with pediatric ICU, we're showing up to round the doctor, but what do we, like, what do we submit? Do we submit on the application?
So after we finish with Dr. Cohen, then I go back with you to pediatric ICU and you give me a report on your patient.
Oh, okay. And what's the date for Broward?
So let me first find out what the date is for Memorial. So it looks like December 2nd is when we meet with, or is it November 30th? All right, my brain isn't serving me well. So it's either the 30th or December 2nd for rounds with Dr. Cohen at Memorial. And for Broward, it's this Friday. Mary, you have a question? You pick your patient. Yeah, a patient on mechanical ventilation. Hopefully there is one. Yeah, it depends on your clinic instructor. Some clinic instructors, you know, see that you're there from early and then by noon they're saying you can go, and then maybe they use that time to give you your evaluation. And then some clinic instructors say, no, you have to finish the day. So I guess it depends on who you have. All right, so on this Friday, students that are at Broward Health, how many students are in the adult ICU? Who's with you? Lisping?
Oh, yeah.
Alex?
Fridays are Alex.
Oh, what students? Lisbine, you,
Summer.
and some, just three of you.
3 of us.
Okay. Okay. So 10 o'clock on Friday, I'll be in adult ICU. And then the issue that I have with this Friday for the person who's in NICU there and the person who's in PICU is I have a 1 o'clock information session. So I have to leave Broward Health at noon, meaning I'd like to listen to report. Who am I talking to, by the way? Who's in, where are you?
And Chris is big you.
Oh, Chris is picking you. Would it be possible for you to gather your report on Wednesday when you're there? That way on Friday, if I could get to you like 9:15. And you can give me a report from 9:15 until 10, well, it won't take 45 minutes, but. If you can give me a report early on Friday. So I think it would help you just to know, pick your patient on Wednesday. Just so you don't have to spend, like, be crazy. Oh my God, I have to be ready at 9 o'clock. What am I gonna do? On Wednesday, you could figure out a patient that's been there for a while.
Yeah, once I can get everything together for you,
Okay,
and then have it,
ready for me around 9:15 on Friday?
yeah,
Okay,
and then Friday I'll do everything else I need to do.
okay. Like get all your current lab values, blood gas, vent settings.
Yeah.
Pardon me. Okay. And then Chris, I will see you after 11 o'clock on Friday. All right, so now we know what's coming up for the end of this week, next week.
Yvonne, you're talking about a week from this Friday, right?
No, no, a week from this Friday, you won't be here.
Where will
It's
I
a
be?
holiday.
It's Thanksgiving.
Oh, that's right.
Yeah, next week is Thanksgiving week.
But I'm not gonna be here. You're talking about this week?
Yeah, this Friday.
I'm not gonna be here this Friday.
Oh,
I could-
perfect.
I can do it Wednesday. You want me to do it Wednesday?
I'll be at Broward on Friday,
Oh,
so. We'll figure out something for after Thanksgiving.
okay. Well, I mean, I can gather the information on Wednesday and we can figure out whenever you want to do it. But I'll prepare it as if I was going to do it on Friday.
That would be okay.
All right, and then if you wanted to Zoom or you wanted to, like, however you wanted to do it from there, at least I'll have the information.
Okay.
All right,
We'll talk about it later.
copy.
All right, so the technology continues, and now you guys are delivering medications via IV pump, where the dosage is scheduled according to dosage over time per body weight. You have the pharmacy that helps you out with this. So they're going to go ahead and mix the solution for you. But you do have to know some things about putting the medications in the IV pump, setting it correctly, and then attaching the tubing to your aeroneb. So having an aeroneb in line is something you guys are familiar with. And when you put in your unit dose, typically you just open a little cap and put your unit dose inside the nebulizer, the aeroneb. So having the IV running continuously, you open the cap, you screw the IV tubing directly onto the aeroneb, and it just drips in at a certain rate per hour, and it nebulizes continuously that way. So that's what you'll be doing at the bedside. So I'll give you a little bit of information about Velletri. It's a brand name. The generic name is epoprostenol or epoprostenol, which is a vasodilator in general. I think I'm telling you stuff that's on the next slide. But just to give it to you briefly. So epoprostenol is a vasodilator. When given, it relaxes the smooth muscle around the blood vessels. This is nothing new with nebulizing a pulmonary vasodilator. When patients have severe pulmonary hypertension, how can you get those pulmonary vessels to relax? So in the past, it was called Flolan, another brand name. The problem with putting that in with the ventilator circuit is every 2 hours, you had to change out the expiratory filter because it clogged the diluent is glycine, I believe, and it was clogging the filters. So now Flolan has gone by the wayside, and now we have Velletri taking its place. How often do you have to change the expiratory filter with Velletri? I don't know that. So that's something we have to find out. How does Velletri improve oxygenation? The drug is also known as prostaglandin I2 or prostacyclin, which are vasodilators. If this medication is given systemically, it causes hypotension. So systemically, do you know what that means? Yeah, an intravenous line in the vein, and it goes throughout the entire body. I guess the ideal word is parenteral delivery, but I figured via IV is better understood. So
that's why it has to be nebulized.
yes. So if you give it via IV and it goes to the whole body, now you've got low blood pressure. Yeah, it's going to dilate the pulmonary vessels, but it's going to dilate everything. Now the blood pressure bottoms out. So that doesn't work. So if we give it via inhalation, it's only going to go to alveoli that are open, and it'll affect the blood vessels around the open alveoli. It causes increased cyclic AMP in the smooth muscle cells, and this results in smooth muscle relaxation. So I'm thinking, do you remember listening to the video that I showed you when we were talking about nitric oxide and how it dilates the vessels, and it went through this little explanation? I thought it said cyclic GMP. So the articles that, like Brian Shapiro sent me the articles and I'm reading them and they're talking about, no, it increases cyclic AMP. So you guys don't remember that either? Okay, so we're good to go. It should be the same, whether we're giving nitric oxide to dilate pulmonary vessels or we're giving Velletri to dilate pulmonary vessels. The mechanism of action is the same. I should write that somewhere.
Does it matter if it's AMP or CMP?
It matters because I want to understand who's correct. Because I thought cyclic AMP is also the mechanism of action for albuterol, right? Doesn't it increase cyclic AMP and cause smooth muscle relaxation around the conducting airways? That's cyclic AMP. You guys didn't have to know that?
When we would call smooth muscle relaxation.
She said it was a beta-2 agonist, and that's all we have seen.
Oh. Yeah, when you stimulate the beta-2 receptors in the muscle cell and it gets inside, it increases cyclic AMP and then the muscle relaxes. And then the article that I saw, it says, okay, you give Velletri, it increases cyclic AMP and the smooth muscle relaxes. It's like, okay, that makes sense. But when we were hearing about nitric oxide saying cyclic GMP, I thought that constricted blood vessels. So I wonder who's correct. So I just wrote mechanism of action is the same as giving nitric oxide. They both have the same mechanism of action. Go ahead.
Sorry, Yvonne, didn't mean to interrupt. I was just gonna ask, is it a test question? Are we gonna, like, on the test or no?
No, it's not a question on the test. When inhaled, Velletri will go to ventilated alveoli and get absorbed by the smooth muscle and the pulmonary blood vessels. This improves ventilation perfusion mismatch. Remember that was the same thing with nitric oxide. When you inhale nitric oxide, it's only going to go to the alveoli that are open, obviously. And then it'll get absorbed into the blood vessels around the open alveoli. So the only blood vessels that are dilating are the ones that are next to open alveoli. Because imagine if you had a collapsed alveolus and you open up the blood vessel around a collapsed alveolus, that would make the shunt worse. Because now you're encouraging blood flow across an alveolus that's not working. So you'd have a lower oxygenation, more shunting. So the beauty of it being inhaled, it's only going to get inhaled into alveoli that are already open, and it'll dilate the blood vessels around those open alveoli. So knowing that, does that last sentence make sense? No? Yes? Only one yes out of 13? 2 yeses? 3? Ren, what do you think? Why does Velletri improve VQ mismatch? No?
Oh, yeah, I'm gonna get it. I just gotta review the requirements, but it's not so down.
Oh,
Don't worry, I'll be ready.
all right. All right, so Velletri, I've got the indications here, but using it for refractory hypoxemia with ARDS, it's considered off-label. It's not FDA approved for treating refractory hypoxemia with ARDS.
That's typically who gets Belitri though. That off-label use.
Really?
So. I wonder about insurance.
Yeah, exactly. Is the insurance going to say we're not covering that?
Everything below that is not.
Is it like the same as nitric oxide where the only like diagnosis that's technically FDA approved is for persistent pulmonary hypertension? Or is everything outside of that off label?
The only one that's off-label that I know of is the refractory hypoxemia.
But those are.
But pulmonary hypertension, yes, it is FDA approved for pulmonary hypertension.
Yeah, I saw it. I looked it up on it.
You did,
It says AMP
AMP?
for the cyclic AMP.
Oh, okay, okay. All right. So what if you look up nitric oxide mechanism of action? Does it say cyclic AMP for that? All right, so with refractory hypoxemia from ARDS, patients are hypoxic because of the edema, the collapsed alveoli. If we can open up the blood vessels and allow more blood flow, they get oxygenated better. I guess that's the thought with treating refractory hypoxemia. If you open up the pulmonary blood vessels, you're going to have better VQ mismatch, I guess. So when you do that, yes, the patient's oxygen saturation improves. But if you look at the studies saying, okay, it improved their oxygenation, but what's the bottom line for something being effective? It would be that the person gets better, they don't die. So if a patient gets Belitri, their oxygenation improves, but then they die, was it really helpful to give them Belitri?
It is helpful
So-
for improving oxygenation,
And that was it.
and that's about it.
Yeah. So the outcomes don't improve, and I think that's why it's remaining off-label from FDA. So it works, oxygenation does improve, but it doesn't really change the mortality rate of the patient.
But like the research they did, like, is it based off of like these patients could have other problems other than refractory hypoxemia? So if the drug did its job, then them dying may not have anything to do with whether the Belitri worked or not.
Exactly, exactly. ARDS ends up being multi-organ failure. It might start off in the lungs, but it ends up being multi-organ failure. So improving oxygenation is only one little piece of the pie. What about the rest of it? Yeah, very good point. Can you understand how Belitri helps pulmonary hypertension? Can somebody explain it to me? And then the pressures in the pulmonary vessels decrease. Okay, good job. So when you give it, the pulmonary vessels dilate and then the pressures inside the pulmonary vessels go down. So understanding that, can you understand how it would help right heart failure? So when the right ventricle contracts, it's contracting against the resistance in the pulmonary vessels. And if you have a failing right heart and it's got to pump against high resistance, it fails quicker. It's not going to do a very good job at pumping. But if you take away that high resistance by dilating pulmonary vessels, now the right heart doesn't have to work as hard. So I guess it can rest and get better. So that's why right heart failure is one of the indications for giving a pulmonary vasodilator. Yes, no?
Yes.
Pulmonary embolism, you get blood clots that occlude pulmonary vessels. That creates a huge resistance for blood trying to flow to the lungs. By giving a pulmonary vasodilator, now you can get the blood around the clotted vessels and to the lungs.
Question,
Okay,
so the pulmonary embolism, if the vessels dilate, would it move, would it by the guy, the vessels being dilated, doesn't it give it a chance for the embolism to move?
yeah, good point. So if you have something stuck and now the blood vessel relax, can the blood clot travel further down before it gets stuck in a smaller vessel?
Yeah, because when you get an emboli, I know they give you medications to try to break it up. And then, yeah, so once you start taking that and then it starts shrinking and then you dilate the vessels, when it like give it a better chance to go to your heart too, right?
If it's in the pulmonary vessels, it can't go anywhere else.
Okay.
Once it gets stuck there, the vessels start getting smaller and smaller until they're capillary size. So it can't get past the lungs to the head.
Okay.
Once it gets stuck in the lungs, that's the only place it can go.
Would that be wouldn't that be a bad if it gets stuck in the lungs?
Yeah, it can cause dead tissue beyond that part that's blocked off. Yeah.
I think we should squish that off. It's an option.
You don't want to give it for pulmonary embolism?
So.
Tiffany?
I have a question about race. So that's why it, the race of the heart is weak and fluid pump against the resistance of the pulmonary arteries. What might cause the high pressure in the arteries for that?
With chronic hypoxemia, with any hypoxemia, pulmonary vessels constrict. So if you have somebody with COPD and they've got long-term period of low oxygen, their pulmonary vessels are always constricted. And that's why they end up with right heart failure. Other than COPD, there's other reasons for pulmonary hypertension. I think scleroderma is one of them.
So it would be like other underlying conditions.
Leads to the right heart failing. Yes. Yeah. There could be an infarct to the right ventricle. I guess if the right coronary artery gets occluded.
Or like the muscle.
Yeah. So then there's nothing wrong with the pulmonary vessels, but we could help the heart out by dilating them anyway. And then that way, this infarcted muscle has less resistance. Good question. It says this Velletri can't be used for long-term treatment. It's just used as a bridge while waiting to implement other treatments. So it apparently after a week or so, it no longer works. I guess the body starts producing, is it endothelin? Something that causes more constriction. So to use it for longer than a week, it's not really a good idea. And it's not going to work. What are some bridges? So maybe going to ECMO, maybe implanting a ventricular assist device. I can't think of anything else as a bridge, but that's what they're talking about as far as a bridge. It's treating the patient, giving the pulmonary vasodilator, and while you're giving it with the thought that, okay, we're going to fix this or do that, and the patient's going to be better, and then they won't need the pulmonary vasodilator anymore. So it's up to the respiratory therapist to set up the equipment for inhaled Velletri. Part of it you're familiar with. So setting up the AeroNeb, You place it on the dry side of the humidifier. And then one article, which I'm not sure how reliable that article was, said you can put it on either side, either the dry side or the wet side. So the picture that I saw from Brian, it's on the dry side of the humidifier, so we're going to stick with that. You're going to set the AeroNet box for continuous. So instead of it shutting off in 30 minutes, you want it to run continuously. And then you're going to have IV tubing coming out of the IV pump that has the Velletri in it, and you screw it directly onto the AeroNet. I don't know why pictures cut stuff off when you import them, but I think we get the gist of what's going on. This is your job. Can you figure all this out? That's a lot of spaghetti, isn't it? This is going there, here, this is going there. Do you see the AeroNet? All right, so we've got I'm having a hard time making out where the inspiratory side is. Guess it winds down and is here. So I'm assuming this is coming out of the inspiratory port from the ventilator. And then you've got your AeroNeb. Do you know what this cable is for?
That's the power.
Okay, so that powers the nebulizer. What does it connect to? Oh yeah, it could connect to the vent, but what else? The control box. And then you see some tubing screwed onto the top. That and the IV tubing. So that came from the IV box. I can't figure this one out.
Some kind of sensor.
Oh, that might be
Like a flow sensor looking type thing.
You've been in CVICU? And you've seen the setup? Oh, oh,
I don't want to know.
yeah, I don't know what this is for. But everything else we figured out. So then you set up the IV pump with the Velletri solution. So you'll get that from pharmacy. The dosage goes according to ideal body weight. And I know I tell you guys this, I'm repeating myself, but I always wonder, ideal body weight comes from the patient's height. Have you seen anybody measure a patient's height? Me neither. That's it, right? So I wonder how reliable this is. Like, do they eyeball it? Oh, Tiffany, you're 6 feet tall. And then they go and figure out this huge dosage and you're not 6 feet tall. You know, I just wonder about that. So yeah, ideal body weight is calculated. And then the maximum dose, the dosage is in nanograms. Nanogram. Oops, I didn't spell that right. Nanograms, NG. Nanograms per kilogram per minute. So you're told the rate in mLs per hour. And the IV pump will also tell you how long that bag is going to last. So as it's going into the patient, you know, if it says like 1 hour left, you need to be ready with your next IV bag to switch it over to the next IV bag. You don't want it to run out, start alarming, because just a few minutes without the Velletri running, the pulmonary vessels will constrict, and then you'll see your O2 sats start to fall.
You want to be calling pharmacy right away when it says 1 hour left then.
Because it takes pharmacy a lot longer than an hour.
Then it should.
Oh,
Prior, maybe 2 hours. Just a sign.
Like cover your bases.
Is it harder to reverse that when you run out of the dosage and that happens to the vessels, they constrict again? Is that harder to reverse when you give?
Good question. Like what happens if that, you run out, your pulmonary vessels constrict, and now you get the new bag of Voletri, you hang it. How long does it take to reverse the vasoconstriction? Good question. I don't know.
Because we get so many calls like that. Oh, my bag's about to run dry. Okay, why are you calling me when your bag's about to run dry?
Oh, no kidding.
Sorry, I got triggered.
So that happens a lot, eh?
More often than it should.
Oh, okay. So you are given an in-service on how to run the pump, like how to set it up, how to run the pump. I'm telling you, your job gets more and more complicated all the time.
The further we get deeper in this, it's like. This is
I'm
so-
hey, Yvonne, is that a typo? Is that supposed to be milligrams per kilogram per minute?
She just said nanograms.
No,
I didn't
Chris, it's
hear
not a
it.
typo.
Okay, sorry.
It's a nanogram. A nanogram is, I think, bigger than a picogram,
That sounds made up.
smaller than a milligram.
Yeah.
In the refrigerator, Voletri is stable for 8 days. At room temperature, it is stable for 24 to 48 hours. So I think the bags are small. It's not like you have to worry like, oh my gosh, there's still some in here and it's been 2 days. The bags are small and you typically have like a 24-hour run. Can Voletri be given via high flow nasal cannula? The answer is yes.
You can nebulize on a high flow, right?
Mhm. Yeah, so it'll go into, you add it to the circuit, it goes into the nose. And from there it gets absorbed into the lungs. Typically a higher dosage when doing it via a non-intubated patient compared to intubated patient. Of course, non-intubated, you're going to have some room air entrained. Maybe some of the Voletri gets lost to the atmosphere. And that's it. So that's all I have on Voletri. All right, so 10:25. Let's do some lecture on your next exam, a physical assessment of the pediatric patient. So we'll talk about it now, but it's not going to be on the exam next Monday. I just want to get a head start because.
Yvonne, on that exam, do you define if our patient breathes above 20 a minute? That's tachypnea, right? On the exam,
Is respiratory rate 20 per minute considered tachypnea?
above,
I thought it was above 24.
so above 24.
Are we talking about neonates?
No, just on the, like, the scenarios, because that's where I got that idea, because, so on this scenarios PowerPoint. I guess when we have that exam.
Oh,
Yeah.
24 in my mind is considered tachypnea.
Okay, so if we have a patient with like respiratory rate of 23, we don't have to correct that, we can leave them alone.
Yeah.
Okay. So we should do
Do you guys need a break? It's 10:30.
Okay.
You don't want a break? Nobody needs a break? All right.
You need a
You
break?
want a break?
No, my thought is I should, if you guys are okay with this all being on one recording?
Yes.
Okay. All right, cool. Seems like most of this course, we've talked about neonates. And not too much with pediatrics. Yet with the state course numbering system, the course is called Pediatric Respiratory Care.
So
Um,
maybe it should be neonatal and pediatric.
They should have a neonatal and pediatric respiratory care course number that would fit better. So here's our chance for talking about pediatrics. And we start off with doing an assessment on a child. How do we know if they have a respiratory illness when they can't talk to us? They can't say, I'm having a hard time breathing, I have a sore throat, I don't feel good. So you look at their behaviors and you compare how they're behaving to what they normally behave like. So the first one mentioned is appetite. So a decrease in their appetite is a signal that they may not be feeling good. So decreased appetite might be a sign that they don't feel good.
These would be things that the parent would have to be vigilant of. prior to-
Yes, yes. So when there's a stuffy nose, and we know that infants and young children, do I want to include young children in that? I'll stop with infants. Since they breathe through their nose and their nose is stuffy, when they're sucking on a bottle, they can't breathe through their nose. And it's going to cause them some distress. So they're not going to want to feed from a bottle because they're going to start associating that with having a hard time breathing. So same thing with eating food. Somebody's having a hard time breathing, it's hard to eat. If you're struggling to breathe and you're trying to put food in your mouth, it's just hard to eat. So looking at depressed appetite is a sign that something might not be correct. The second symptom is physical activity. So when they're typically active and then all of a sudden they're just laying around all the time, that's a sign that they're not feeling good. And as far as level of awareness, how are you supposed to ask them who the president is or what year is this? What's that?
Is it like if they're tired or not, or extra sleepy?
Okay, sleepy. And then infants, when they're awake and alert, they look to focus their eyes on you. And if they're not doing that, that's a sign that they're not feeling well. So what I have with level of awareness, they follow their caregiver with their eyes. And then versus staring straight ahead.
Or babies,
Yeah.
not pediatric.
So infants will normally follow their caregiver with their eyes. If they just stare straight ahead, that is a sign that something isn't normal. The next thing is presence of a cough. And by listening to how they're coughing, it'll give some clues as to what the problem is. So if they have just a sore throat, their cough is going to be dry and persistent. Versus like moist or strong or I don't know, just dry and persistent tells you there's an issue in the throat. If it's the larynx and trachea, the sound is harsh, barking, or brassy. So that's when there's laryngeal swelling, and they may have croup. If the lower respiratory tract is in bronchospasm, then you hear high-pitched wheezy sounds. Now, as far as the wheezing, if you hear it on exhalation, then it's produced by intrathoracic airways. Do you remember when we were going through pulmonary function, how we had to remember in our minds that inside the thorax, when you have the negative pressure during inspiration, it opens up the airways. And then on exhalation, the airways close a little bit. So it's typically on exhalation, when you get that closing is when you start hearing the wheezing. The air trying to get through a really small area creates a wheezy sound. So that's why you hear the wheezing on exhalation from your conducting airways inside your thorax. But negative pressure pulls in everything outside the thorax. So if it's your larynx that is really swollen, it's hard to breathe in because during inspiration, it closes a little bit. And that's when you hear that sound when the babies have croup. And of course, if the airways are really narrow and there's no airflow, you hear very diminished breath sounds. And the next thing we look at is work of breathing. Do I have some notes on it? No, just work of breathing. If they have labored or difficult breathing, it'll be characterized by sternal retractions, nasal flaring, short sentences, or short cries. There's no place on here to add some notes. What about on the next one? Let me add some notes here. What is it? Oh. So I wrote, when a baby or child is hypoxemic, they will initially be agitated. With continued hypoxemia, they become lethargic. So I put a question up there. What causes paradoxical chest movement in infants and young children? Do you know the answer to that?
Is it asthma or no?
Yes, you feel correct. If they have pneumonia, yeah, pneumonia can lead to it. Why? No. What does fluid do in the alveoli? Does it change the compliance?
It reduces compliance. Oh, is it reduced compliance?
Yes, very good. So airway obstruction causes paradoxing, reduced lung compliance causes paradoxical chest movement.
So it was asthma also?
Asthma can also, yes, very good. Can I erase it? All right, next we look at vital signs. And vital signs can range so much between a newborn and an 8-year-old. After 8 years of age, vital signs are pretty much like an adult. So how are you supposed to know what's normal? You notice that as a person gets older, heart rate, normal resting heart rate gets lower. So neonate was what, 120 to 160? By the time they're 2 years old, normal heart rate is 110. And by the time they're 4 years old, 100. Blood pressure goes up as we get older. So the bigger we are, the more our blood pressure is to circulate our blood. And as we grow, our respiratory rate starts out fast. Normal was 40 for a neonate. By the time we're 2 years old, it's down to 28, and then 8 years of age, 20. So to predict blood pressure, I have a formula for you. It's 90 plus 2 times the age in years. So if you're 1 year old, what should your systolic blood pressure be? (92) systolic. And then for diastolic, you subtract 30 millimeters mercury. So diastolic blood pressure 30 less.
30 less than systolic.
Yes. So if somebody is 4 years old, what should their blood pressure? Oh, it tells you. How about 6 years old?
102,
Versus
102.
Yeah, I get more than 8 years of age.
Yeah, what do you do?
wait,
So if they're 6 years of age, multiply that by 2. So 6 times 2 is 12. Now add 90 to that. So that would be 102.
Yes,
So that would be their predicted systolic blood pressure.
yes.
And then subtract 30,
72.
72. So 102 over 72 for a 6-year-old. I know the 8-year-old shows a little bit lower, but that's the formula from American Heart Association, Pediatric Advanced Life Support.
These numbers, can you just use a formula?
Yes. Yeah, definitely. And then also looking at vital signs and knowing if you've got good cardiac output and good perfusion to the organs. You use capillary refill. So that's not something you hear about much with adults. But with infants and children, capillary refill is a way of assessing whether or not they're septic. So by pressing down on their skin for several seconds, when you let go, if there's good blood flow in the body, it takes about 3 seconds for the area to reperfuse and not be blanched looking. If it takes longer than, is it 5 seconds? No, I was giving you wrong numbers. Less than 2 seconds, the color should return. More than 2 seconds indicates poor perfusion. So capillary refill is used to evaluate perfusion. If you press down on an area of the skin and then let go, it should take less than 2 seconds for color to return. This is normal perfusion. If it takes more than 2 seconds, it indicates poor perfusion. And that's when you question septic shock. Because it's typically reasons for poor perfusion in young children. It's not like they have an MI or something like that. It's usually related to infection. Okay, I can erase it. Okay, and now causes of upper airway obstruction. We'll talk about croup and epiglottitis. The medical term for croup is laryngotracheobronchitis. That makes sense, right? The larynx, trachea, and bronchi are inflamed. There's inflammation and swelling of subglottic structures. So we know the glottis is the vocal cords, the opening between the vocal cords. So subglottic would be below the vocal cords. And then the trachea, larger bronchi are inflamed. There's a small potential for ventilatory and oxygenation failure. Small potential means very small statistics as far as how many babies get it so bad that they have to be intubated. So it's typically we can treat it and then they're okay. It occurs in children aged 6 months up to 6 years of age. But I want you to know something else. I think I want you to change that to 3 years of age. Younger children end up getting croup, and then the older children end up getting epiglottitis. So. Oh, it doesn't show up. You see my 3? Okay, so 3 years of age. So it's usually in younger children that end up getting croup. How do I? No, I guess I have to end the show to go to it.
The thing that's different about a Virgo vacation home, you always have the whole place to yourself. Just you and your people.
I'm glad it's appropriate. Sometimes they've got like really inappropriate stuff coming up.
We're doing a video on croup, and this will help people in the community out there to understand exactly what croup looks like. This young lady actually has a fairly impressive croupy cough, and this kind of this seal-like barky cough and some stridor, and
Can you tell that she's paradoxing with her difficulty breathing? You see it? Yeah, look at the chest.
croup. And this will help people in the community out there to understand exactly what croup looks like. This young lady actually has a fairly impressive croupy cough, and this kind of this seal-like sparky cough and stridor. And not going to listen to the other people what it sounds like. She's already had some ischemic epinephrine, and I think she got steroids at the outside hospital before she was transferred into the children's hospital. So listen to this. So the typical treatment of croup is basically steroid, and you can use 0.6 milligrams per kilogram, which is Decadron, dexamethasone, and then also the epinephrine. A lot of children can actually go home, but she's unfortunately going to get admitted. Agreed.
Agreed.
Yeah.
Mom doesn't look too happy.
Just listen to that.
She's got it on inspiration and exhalation. Influenza viruses. Wow, I don't have music with mine.
That's really giving it character.
7 years ago.
Yes, coronavirus doesn't change.
No, I know. No, it's not just. It's been.
Have you guys heard it in the pediatric? in the video?
What, you heard a baby with croup?
No, I was wondering what was a big deal they actually. did it.
No, I've never heard of it. It's wheezing, it's just.
Don't get excited, it's just wheezing.
Because I know RSV is like bigger.
It is, yeah. it is.
So I was wondering.
Oh.
Albuterol's on back order, so. it's
Again?
probably-
What's on back order?
Albuterol.
Oh, my word.
It's like COVID.
It's bad.
Wow, so does that mean rationing or just borrowing from another hospital or?
So it means rationing, or it means you have to order a different kind. Yeah, and it's who has it available.
Oh, my word, that's crazy.
Yeah, it's not good in the ER. It's-
No. But I guess that helps with all these patients that, have you given a lot of albuterol treatments and you can't figure out why? You hear no wheezing, there's no respiratory distress. No sign or no history of asthma or COPD, and you give it because it's ordered.
Because it's preventing
No. No, you don't need to have albuterol to prevent.
You really have to question the
Bronchospasms.
doctors as to why they're ordering it. Because if it's not for bronchospasm and it's on back order, then it shouldn't be ordered.
Yeah. I agree. So the patient presents, of course, with the croupy cough. Sternal retractions, of course, because when you have airway resistance or airway obstruction, it's going to make for a harder work of breathing. They will have a 2-day history of low-grade fever. So that's typical of a virus. Have you heard this before, where you get a low-grade fever with a virus, but you get a high-grade fever with a bacterial infection? Yeah. Okay. So low-grade fever, think virus. And what else did I want to tell you? And then spasmodic croup is, the parents hear the baby during the night and they're, it's like, oh, wow, that's bad. Let's try turning on the shower and getting it really steamy in the bathroom, see if that helps. No, it doesn't help. Okay, let's get dressed. We're going to have to go to the ER. By the time you get to the ER, the baby's fine. The next night, you go through the same thing again. You get them ready to go to the ER and then they're fine. So that's spasmodic croup. It goes away on its own.
So we just wait to see if it goes away. And then if it doesn't go away, we go to the ER.
Yes. No. You need to know how to diagnose croup. It's based on chest X-ray, along with history and physical. So we talked about low-grade fever, a virus. We talked about 6 months to 3 years of age. Now you're going to look at chest X-ray. So the findings on chest X-ray are, am I getting ahead of myself? Where's my picture?
Was there a picture on slide 10?
Yes. So not chest X-ray, but a neck X-ray will show the narrowing. So where it's, you can see some blackness, that's air. And it's how narrow it is up here in the larynx. So that's all this tissue is swollen and it's pushing into the airway, and that's what's narrowing the airway. And it's said to look like a steeple sign on a church. I don't know of many churches that have steeples anymore, but it used to be a way of describing the x-ray is the steeple sign, because it looks like the steeple on a church. So I'm just throwing that out there in case it still shows up on your exam in that fashion, your national exam. Steeple sign, you just have airway narrowing, subglottic airway narrowing. Hospitalization is required if there's stridor present at rest. The baby needs steroids. So steroids can be given orally via IV, but can also be inhaled. What steroids can we give to kids that can help reduce inflammation? Racemic epi, yes, but that's not a steroid. Yes, very good. Pulmicort. So you would give them some Pulmicort in the ER along with the racemic epinephrine. If you have really bad retractions, you can give the racemic epinephrine via Heliox. Because Heliox is such a light gas, it'll get the medication down easier and past that obstruction. Racemic epinephrine, vaponephrine, how are you guys seeing it? Is it in unit dose? And is it brand name or generic name on the unit dose? Like it's generic, so it just says racemic epinephrine. What dosage do you give to children? You afraid to say it because it might be wrong?
I'm going about a whole PowerPoint. That's what's happening.
The percent solution I have is 2.2% solution, and you give 0.5 mLs of a 2.2% solution. So you give 0.5 to kids, you give 0.5 to adults. Why would you give such a big dosage to children? And the answer is, do you know the answer? No. Their airways are so tiny that a lot less medication actually makes it through their airways into the lungs, or in this case, to the larynx. So did you write down the dosage? Do I need to type it in? 0.5 mLs of a 2.2% solution. It will get to the swollen area.
Do it systemically, would it take longer to,
Racemic epinephrine?
or can you give that systemically?
Yeah, you can give sub-Q epinephrine to patients.
So that, I guess, just reach the targeted area slower or not be as effective?
Yeah, so it has to go systemically and also get to the airway. So that can be done. So most children are treated successfully in the emergency department with vaponephrine and Pulmicort. If retractions and stridor continue after treatment in 2 hours in the ER, the child will be admitted for closer observation. So we've got two of them there. All right, we'll do the 3 slides on epiglottitis and then we'll stop. So this is caused by Haemophilus influenza, which is not a virus. Isn't that weird? When you see the word influenza, don't you think the flu, being really sick with the flu? And it's not. So is it a bacteria? Yes. Sometimes Staph aureus can also cause epiglottitis. And from the name, you can tell that the epiglottis swells. So epiglottitis, the epiglottis is swollen. This affects the older kids. So it says the ages are 1 to 5 years. So 6 months to 3 years with croup, 1 to 5 with epiglottitis. We shouldn't be seeing epiglottitis anymore because kids are given vaccination against Haemophilus influenza. But there's other causes of, excuse me. There's other causes of epiglottitis.
If the parents are anti-vaxxers, then we probably would see it if they don't have a vaccination.
Yeah, so what happens if parents say, I don't believe in vaccines and I don't want to give my kid that vaccine? Are they still allowed to go to daycare or to school? Probably not, right?
I think that's the only reason I got my vaccination. Is my mom.
Oh, really?
Yeah.
So once you have to go into like a public setting, now it's required?
At least in the last time.
Yeah. So beta hemolytic streptococcus, we know it as strep throat. So strep throat can cause swelling of the epiglottis. Pathology, it gives you some more detail. You get swelling of the epiglottis, aryepiglottic folds, the arytenoids. It leads to difficulty swallowing and airway narrowing. The way that the infant or child presents, it's abrupt and associated with a high fever. Do you see the difference between croup being a 2-day low grade? This one is abrupt and they get a high fever. Severe sore throat. Their voice sounds muffled. So because of that swollen epiglottis, when they do talk, it sounds muffled. It's very hard to swallow when your epiglottis is swollen. So all of the saliva that their mouth produces, instead of them swallowing it, it comes forward and drools. So there's a lot of drooling, and you can see it in the picture. They are short of breath. They sit in a tripod position. So to describe that to you, when they're leaning forward, if they're like sitting crisscross on the bed, they'll lean forward on their arms. And what that does is gives them the ability to open their airways some more. So they're trying to get air. And they do it without even going to school to learn how to do it. It's just so amazing. It's just the body's natural response to an obstructed airway is they're opening up their neck to try to get more air. How do you diagnose epiglottitis? You diagnose it with a lateral neck X-ray. And on the lateral neck X-ray, you're looking for a thickened epiglottis. And then this is called a thumb sign. It looks like somebody put their thumb on the X-ray and then the picture was taken. So that's like the lay term that they use, that they might use to describe the X-ray for you on your exam. A thumb sign, but it's just the swollen epiglottis. This is a 4-year-old girl who has epiglottitis caused by Haemophilus influenza type B. She prefers to sit and appears anxious. The child assumes the characteristic sniffing position to maximize the patency of her airway. Another neck X-ray showing the swollen epiglottis. So the balance that you have to do with epiglottitis is doing anything to the airway can cause the epiglottis to swell a little bit more and completely occlude the airway. So you're just worried that at any moment the airway can be occluded and now they're not going to get any air. So to use a tongue depressor and try to visualize the epiglottis, just that maneuver itself can cause further swelling of the epiglottis. So it's believed that don't do anything. Maybe give them some air, a cool aerosol to breathe in. And take them to OR to establish an airway. That way they can do a rapid tracheostomy if they can't get the endotube past the epiglottis. If they have to go that route, then of course they'll heavily sedate the baby or the child and put them on the ventilator. So what works against Haemophilus influenza type B? Yes, very good. Ampicillin and cephalosporin. A 3-year-old child is in the ER. She is pale with a temperature of 103 degrees Fahrenheit. She's in marked respiratory distress. I put that word in there. Have I told you about this word before? This is what the NBRC likes to use. So when you see it, it means intubation. Marked respiratory distress. She is sitting forward, drooling. You have just placed a cool aerosol mask on her and a lateral neck X-ray has been taken. Your next step would be to A, use a tongue depressor to view the epiglottis, or B, transport the patient to the operating room for intubation and possible tracheostomy. Letter B. I kind of gave it away a minute ago, didn't I? And that's it. So we can do the rest next week. You guys, the semester's almost over.
One year, 2 weeks left.
Yes.
Yeah.
Very quick.
All right, so I will stop the recording, get the lab set up. So I'm anticipating being ready for the first lab to run at 11:30. Yeah. So 11:30 to 1:30, and then the second lab from 1:30 to 3:30. Sound good?
Yeah, thanks, Yvonne.
You're welcome.
Thank you.
You're welcome.